Welcome back, everyone, to the Pursuit of Health podcast. I'm your host, Dr. Eric Fethke. Today, in part 2 of episode 5, we continue our conversation with 2 neighbor colleagues of mine who are physicians who are talking about the financing of healthcare. In part 1, we talked about some of their ideas about how we are spending our money. Here in part 2, we dive further into this conversation and discuss the future of healthcare financing. Dr. Wilken discusses the patient medical-centered home and why he believes that this may be a solution. And Dr. Silber looks forward to financing that allows everyone to access high-quality healthcare in the future in the United States. So join me now as we dive further into how we pay for our healthcare and what we are getting with Dr. Silber and Dr. Wilken on the Pursuit of Health podcast. So we're cautioning, not only the payers, but our patients, most importantly, and our colleagues and our student colleagues to say, what really is important, it is important to know that the patient feels like satisfied with the care they're getting, but how you achieve that is important. And we need to dictate that in a way that is not actually superficial or not truly dictating what the outcome is going to be. If we go off into ordering all these tests because people feel better when you do that in a boutique setting and do all that kind of stuff, they may feel better, but the end result will not necessarily be better. And that's a problem because ultimately that cost goes up and the outcome doesn't change or gets worse. And that's not what the outcome needs to be. So somehow you're both saying, if you spend time with the patient, make a relationship with them, and explain to them about their illness, essentially teach them, tell them what you're doing, why you're doing it, or why you're not doing it, then that actually creates satisfaction. It takes more time to do that, though, right? That's a commodity, time. So that keeps playing into this. But when you do that and you bring the patient along with you instead of 5 minutes in and out the door, then you end up spending more time, but spending less money and get a better outcome. It goes back to that relationship building again.
And that's really, I think that's still, people say, the art of medicine. There still is that relationship there because people want to hear it from someone they trust. It can't just be all algorithm. I would say I like, what's come out of COVID in a way, with the telemedicine and the telehealth, and we're getting reimbursed for telephone calls right now because, it really rewards doctors for spending time with patients in a way that you probably get to do outside of the visit. So, I've maybe heard, and not in my practice, but I've heard maybe in the past where someone said, I just want a refill on my, let's say Flonase was prescription at the time. I just want a refill on my allergy medicine, but the doctor wouldn't do it because I haven't been there for a year, and he needs to see me. Why? Because if a doc spends all this time on the phone, talking to people and refilling their
There's
meds,
the money factor again.
He's not seeing that. So now I do see being able to do telemedicine visits, being reimbursed for telephone calls. I feel great when I just had to go over a lab with a patient and they didn't waste their time
But you're spending time with them again. You're being there again. Time and money is such a big interaction that has been sort of jeopardized and challenged in healthcare. Every time you're talking, you guys are saying, "Give me a little more time." Whether it's with my patient in that setting where you work, Phil, or on a telehealth or something. The more time I have, the more I can interact with the patient. I'm actually saving money, getting better quality care, and in the end, you're both saying that the amount of money you spend does not always translate to the outcome, which I think is the bottom line here, is that, so to speak, the bottom line financially, but that, you go into a boutique setting, they spend a lot more money there, you keep a lot more money, but it doesn't translate to better care necessarily, and if you're don't spend time with a patient and can't do that in a complex patient and just order tests, that again, it costs more, but you're not getting better outcomes. So would you both agree that the amount of money you spend is not commensurate to the outcome, the quality of the outcome?
No,
not necessarily.
It's how you spend it.
It's how you spend it.
We, in this country, and I know you probably, maybe I heard this in your podcast.
Yeah.
But we, when it comes down to it, we're not denying care to anyone. If someone shows up in the emergency room and they're really very sick, they're going to get the care and we're going to pay for it somehow or the other. So the idea of getting everybody into care beforehand and spending a little money up front is important.
Yeah.
So it's just different attitudes. I thought it was interesting, though, in my older practice, people wanted to see high-cost specialists right away. I'm not saying one were the other, high-cost specialists right away. Now when I see patients, and if I do refer them out, sometimes they're like, "You're my doctor.
Right.
Why are you referring me out?"
Oh, that's very powerful.
So,
and I think we all have had that experience. We've all, thank goodness, have been fulfilled in that sense that we really do feel that our patients have that sense of us, and that takes time. And I think we all would agree to say is that's our bedrock. That's where the quality comes from, the relationships we have with our patients, their families, our teams that work with us. That is really where to spend the resources. Not necessarily ordering more tests or ordering more this or referring, but really knowing your patient well enough that they end up trusting you, which is a big commodity. I mean, I think you feel that, Phil, and, you're getting calls all day long. I see you, just asking questions about what would you advise. And I think that's an important foundation to your care. And it doesn't cost more, right?
I think a large part of it is just access to communication with the doctor is a big part of it. And I think, I have to say with social media, the electronic medical records, I think it has given more opportunities to interact in a lot of ways. And I think, if we take advantage of that and be accessible, and like you're saying, that's getting that trust is so key, and it's made a big difference.
So in some sense, the money we spend, you both said it's how we spend it, not what we spend it on, but how we actually choose. And would we both agree, or all three of us, I think we have had this conversation, agree that we don't think the money is necessarily as system-wide, maybe here and there, but it could be spent better than it's being spent right now. And ultimately, it's not that there's not enough money in the pot, so to speak, in healthcare. There's a lot of money in the United States in the healthcare pot. But if we could spend that differently, do some of the things we're talking about, we might actually reduce the overhead cost for our country, which is double the next country per capita, and actually get better quality. Do we all agree with that?
Yes.
Yeah.
I would say, though, what's popping in my head too is, so I'm wearing a couple of hats, so I've been talking mostly about my pediatric hat.
But administratively.
And New York is really wonderful. Kids all get insurance somehow, through Medicaid.
Child Health Plus and things like that, right?
So 98% of the patients I see have insurance. And if they don't have insurance, I have people that figure out why and get them on insurances. So, I don't have this problem with access to care, but I know on the adult side of where, I work, we're talking maybe 30% uninsured, 34%. So also working poor, not having, having competing priorities, when you don't have the money, healthcare becomes less a priority. So those older patients that don't have access to care, they're ignoring problems. They're getting poorly controlled diabetes. They're ending up in the ER when it's too late. And that's money we end up spending on the back.
So we're all paying anyway.
We're all paying anyway. Right. So I'm a firm believer in, we were saying relationship, but when you talk about relationship, you have to have access. So if you have access to primary care doctor, if you have access to your preventive medicines, if you feel like you have the time and the resources to get care.
So you're saying if you see where it works in children, and there are some gaps, at least in your own professional life that you see administratively and otherwise, that there are gaps that the children in New York has filled for children, but not necessarily for adults, and that would be money well spent.
Absolutely.
That would be where you would say, we have the money, but we're spending it in the emergency room. Give me half of that money, and I will save the state money, and that person will get better care and have better access.
Yeah, absolutely. I mean, that's the basis of, I've had conversations with people saying, hey, I work, I can get insurance, it blows my mind. I say, why should they just get what I work for? But this is healthcare. This is dignity. This is what we all deserve. But I think as a society,
and convincing people that you're paying anyway somehow.
You are paying anyway.
Whether
and
through
the most expense, our goal is to be. So I didn't know where this conversation was going, but we talked about how much better outcomes will be if the patients have access and trust us. So and that's in the pediatric world, but the more we provide access to someone that they can have a primary care doctor, the better they'll do in the long run.
So we're going with the foundation again. We're going back to that relationship, foundation, and primary care again. That's where this is heading. It's interesting. The economics are saying, don't go to the specialist. Go again. Let it be driven by the general physician who knows their patient, and that's the part. The patient trusts them, but they know their patient too. That's the two-way part of a patient-physician relationship. Yeah, they trust you, but they trust you because you know them, and that doesn't cost more to do that. It just takes a little more time. And if we had that again, that would be important. And I think if an individual is trying to make that choice and they're out there and they're saying, okay, you just confused me. You're saying if I go to this private place, I may not be getting better care than if I go to a clinic that's well run where other patients don't have the resources I have. Okay, I'm confused. So how do I know as an individual where to go? How do I judge that? What kind of things would you tell somebody to make a decision, a friend, a colleague? Well, you go to that doctor because. What are the becauses in that?
I mean, I think one of the biggest factors is probably care coordination and just, with what you were saying with pediatrics versus adults, it's even more true in the special needs population because the one thing you hear consistently is parents who have been their kids are turning 21, which, for special needs is oftentimes the age where you make that transition. And they've had care coordination up to that point very tightly with the school districts, with their primary care docs, their specialists. So all that's been integrated. And then the one thing that's very consistent is when they hit that age of 21, that care coordination is gone. And families are really left without guidance. I see that in the specialty
area too. All of a sudden, the cruel adult world we joke about. Yeah,
and then there's nobody coordinating. Like I'm biased. I'm a primary care doctor, but that coordination then could happen through primary care, or whether it's a patient-centered medical home where I just mentioned that because it just gives a framework for creating a care coordination, which if an office does that, I think care coordination in an office is key.
So that's something that people should look for that they may not realize. Look for kind of, if there was like a little label on the cereal box or something, this is a place where there's coordinated care. I don't think we label it that way. Maybe at some point, medical home will have a sticker or something, but basically asking not just about the doctor, but their team and the place they work in. How does the whole place function on my behalf as a patient is a question somebody we should be asking themselves.
We're a patient-centered medical home level 3, and I think one of the struggles is to kind of translate to the patients if they know how much goes behind the scene to coordinate their care and what we do for them. So that's a challenge.
And I think one of the things that I've said in my practice, I'm just coming to mind, is once you start empowering your other colleagues, your nurses and your other people in that care coordination, and tell the patient they are part of what I do for you. You can talk to them, you're talking to me. You create that kind of environment. I've had some doctors say, wow, I wish my nurses were as good as your nurses. Well, their training is the same. It's how you've used them, how you've organized that environment on behalf of your patient that's different. If you use the resources of that training, that care is coordinated differently, that you're saying translates to better care, better outcomes in the end. So patients need to look at that aspect. It's not just the doctor, and I know it's hard for us to be humble, but the truth is it's not just about us anymore. It's about the whole system. And I think most of us would like to have social workers and other people to outreach in that too and create that, because that's how you're going to get the population health. So if society is asking, not just an individual now, about these disparities, you're telling us that people who are very wealthy may be spending more and not getting better care. People who don't have the resources may actually, not getting access, but they're getting decent care if they go to a place that is focused on coordination of care. So how would you recommend, as physicians, the policymakers and the people who are having discussions raise the bar for care and make the equity a lot more even playing field with these ideas in mind? How would you tell them, look, Mr. or Mrs. So-and-so working on that, listen to us. This is what we're saying. What are we saying to them?
I think one, and a change that's been very recent as of January that's been huge has been the E&M coding. Right. When we bill at an office visit for primary care, we have to, hit on certain really qualifications in our visit to bill at a certain level. And so to give the government a lot of credit, they've really altered that whole system right now and simplified it so that we can really focus our time better on communication with the family. So I have to.
Do you think they were listening to us eventually?
I think yes. I think yes.
For people who don't understand that concept, the idea was that you'd have like a level 1, 2, 3, go on up, and the higher level of code, you got paid more for those levels of code, but that required that you do certain things in your note, in your time, in your, or the complexity was all done. So it got really tied to a lot of bureaucratic stuff, not necessarily better care. And they've kind of said, wait a second, with COVID and all the stresses and all that's going on, we're going to take that burden away, because it's almost like, do the SATs really prove you do a high score, you're going to be a good student in college? No, it's actually not necessarily one-to-one. Higher level on the codes and higher was not translating to better care. So they basically said, let's change that. And that's something that they've already heard us on.
Yeah, they're doing it because of all the telemedicine too. Because, you couldn't necessarily listen to a heart and lungs, but they've said you have to hit 5 body parts to make it happen. I think something interesting to keep your eye on, and I know they're looking at redesigning Medicaid and the way we pay in New York State. It's going to be out there is not necessarily paying for visits anymore.
Right.
So looking at the total cost of care. So
this discussion is relevant. To have this discussion now, people understand this is coming.
Coming.
Right.
Like if I have, the best way I can kind of explain it, if I took care of 1,000 patients, I had 1,000 patients, and last year, it cost me, $100 on average per patient.
Okay.
Multiply that out. I'm really bad at the math. I say, okay, Silber,
$100,000. Yeah, 1,000 patients, right?
So probably a lot more than that. But Silber, this is how much you have to take care of that cohort of patients now. Take care of them. See some of them 4 times. Get on the phone with them. Do what you need to take care of them. Your nurse could probably do some of it. Your patient educator could do some of it. Your nutritionist can make a call. But it doesn't all have to be within the context of that 20 visits you have per day. That's strictly where we've always traditionally.
So the fee-for-service model is changing.
It's changing, and I'm sure there'll be challenges with it, which goes back to I'm only rewarded if that guy comes in to see me, so I can say, oh, you do have allergies. Here's Flonase, and it didn't take into consideration that he took a day off from work to do that. So telemedicine helped that, loosening it up, allowing other people to work to the top of their license.
So the structure as an administrator, and somebody also here as a director where you work, Phil, as well, the structure of fee for service is one way of doing things that, every time you order a test, you bill for that, you see the patient, you bill that level 1, 2, or 3 and all that. It's kind of, I call it the shopping cart list, your invoice. And then there's the other level, which is more for the quality of care. Again, and you're looking at that and you're saying, we're going to give you X because that's your budget, and see what you can do with it. And if it actually works, or you need a little bit more next year or a little more, that's how the systems, in other businesses would work, and say, this was our budget. We went over, we went under, whatever. And this is what we're getting in the end for what we're paying, versus the incentive to just rack up the invoice list, so to speak, which sometimes becomes necessary if the costs are dictating that way, from our school debt, from the overhead, from all the other things the hospitals might be spending, such as a nicer waiting room or our offices, that are not necessarily getting better care. So we're kind of forced into that fee-for-service model. If somebody just says, we're not doing that anymore, it may be hard to change that mindset, and it's going to be a transition. But what you're saying to everybody is, this is going to change how we deliver care. We're going to grow through these growing pains, but you think that might be better in the end.
It should be, yeah.
Yeah.
Quality is tough to measure, so you'll see them measure it on things like the quality measure. Look at colorectal cancer. For instance, my brother-in-law, I was talking the other day, and he said he got shingles. And he was upset that no one told him about the shingle shot. But he said, my primary was talking a lot about colorectal cancer screening, and that's, he just wanted me to get my colonoscopy. And I said, I realize that because there's a lot of incentives and around primary care, and I think it's a good thing, making sure that everyone gets their colorectal cancer screening, everyone gets their breast cancer screening. These are things that they look at as also that if you could convince half your patients to most not happy. You get your patients to get these things done. It saves us as a society, it saves lives, and it saves money.
Versus what's been happening with COVID lately, when everybody's waiting, getting sicker, and we'll see in a very big way the cost of that. And I think that's coming still. We're going to be shocked with how many people are very sick and had their illnesses go on, and somehow we're going to have to pay for that. And I think I talk about that in the first episode, where it looked like we saved money up front, but to what end? Because when all these people come out and say, look, my cancer or my heart condition, whatever, is now 10 times worse, and you're still covering me, oops, how is that going to happen for the insurance companies who are doing a fee-for-service system, and if we change that model? So if, as we're thinking about some of these final thoughts, and I think, as always, this goes in directions that I really enjoy, that you don't expect. We're talking about, what you get for your money, but we end up talking about how to use the resources that this country already has, a lot of money already in the healthcare system, and just reallocate it in a different way, spend it in a different way, and then watch the outcome, listen to the physicians about what it is that we believe changes the outcome, which is our relationship with our patients. So give us time to do that and build this into outcome models of our community, the people we serve. And let's try this, because the fee-for-service model is definitely not working, and it's driving that, and the education costs and all this are driving it. And so it's not, for those people who are afraid that's going to cost more, we're not saying it's going to cost more. We actually think it might cost less. As physicians, we're not sure this money's been spent well that's in the pot right now. I think if we were going to say to, the policymakers and to our patients, COVID has taught us that. COVID doesn't care, if you're rich or poor. When you walk into the doctor's office, it just sees a human being, a host for it. And we've seen when we don't spend the money well and evenly and equitably, we run into problems in managing something like a pandemic. But before the pandemic, there was heart disease, there was diabetes, there was hypertension. The virus took care of that, but that's still there underneath it all. We didn't do very well with that. So changing the economic model is not only nice, it's not why we changed our career paths or decided it's necessary. We're saying as physicians, this has to happen. I mean, would you agree with that?
Yeah.
If not, we're going to be, we can't keep doing this. And I think that's where the economics are. And we see that, we feel that. So when we finish with each episode, we kind of ask the same question. And, we'll see where this goes, because I always get these wonderful answers, not putting you on the spot, but because I get answers I didn't expect to get, which is, if we're talking about the concept of this podcast, the pursuit of health, where we're going, and we want to kind of say, well, that's what it means to me as a physician in this discussion, in the context of how we spend our money, and are we really getting what we should be for our dollar, and how we change that in the evolution of the financing of healthcare in this country. So with that model, and with you all as primary physicians with administrative backgrounds and stuff, if somebody says to you, so what does it mean? Where are we going? What are we trying to get to? What is that pursuit of health? So Phil, what would you say to somebody that means to you?
I mean, I have to say I've really bought into, I know I keep bringing up the patient-centered medical home, but I think it's a great model, because it really takes into account patient satisfaction, takes into account that practices are looking at their data to drive their decisions. Mm-hmm. It takes into account that there is a case management system. What we mentioned a little bit before about the role of nursing, and I mean, whether it's nursing or any of the multitude of other staff running an office, everybody can play a role and really improve care. And so I think patients pick up on that, and they understand a well-run office. They definitely perceive a higher level of care when they're able to see these different components that are being brought together. So that's a strong.
You say that's
driver.
The way to go.
Yeah, I mean, for me, I've really, like I've said, really bought into that, and I think that, and they're run by, there are these qualifications to become a medical home. They've been well thought through. They're having
physicians and policymakers involved in these things.
Yeah,
and you're not saying I'm proving to you 1,000% that this will work, but you're saying there's a logic to it.
Yeah, it's very logical. That's a good point.
It fits what we do. It kind of is more holistic to what our sense of being a physician is. It's almost, I don't want to put words in your mouth, it's about time that we're starting to think broader. It's not always the physician, the test, the operating room, it's this. If we're going to really deliver care, we have to think about the whole team that's involved in whatever you want to call that, a medical home, a center home. What we're really saying is coordination of care at all levels, putting that network together, making that part of how care is delivered in the United States is going to hopefully translate to better care.
And I think that's exactly what I'm thinking. And, when we have medical students coming through the office as well, it's one of those things that when you have doctors in training, they don't necessarily, in terms of being taught, there's a lot to learn during medical school about all these, lots of facts and other things. But, the business, quality, all those other parts of medicine, need to be addressed as well. So I think somehow that's got to be integrated into medical education.
Because we didn't learn that, did we?
Yeah, it was
kind of left out there. And you're saying also that that's something, make everybody who's involved in this understand that if you're as I use the analogy of a restaurant, if you're the cook in the restaurant, the chef of the restaurant, you need to know how the business is run well in order to deliver a good product too. It doesn't mean you're taking away from the quality of what you're doing because of that. Take that taboo away. And Avi, what would you say? I mean, you've come from a boutique background to a high clinic volume background to something where you kind of found that soft spot which you seem to be happy in. So what is where we're going as a country and talking about healthcare reform and what we're trying to do? So what would you tell somebody we should be aiming for? What's that pursuit?
And I wouldn't be where I am if I didn't believe this, but it's access to high quality healthcare for everybody. And it's not just a human rights issue for me, it's also an economic one. You're going to pay for it somewhere. So if everyone could get primary care, preventive medicine, keep them in the areas and treat them where it's affordable, we're going to do a lot better. And I think some of the other countries have done that better than us. So, I think when they say the best money healthcare could buy, we picture, the rare surgery in Colombia that can only be done in like this heart center of the world. But like 99.9% of us just need access to quality healthcare. And that's how we fix this. And, it really kind of helped me here because I realized how much great care we take of our pediatric patients, and we're lucky to practice in New York for that. And I realized that the adult patients I see don't necessarily have all those advantages. So
the quality starts, and I think we all agree with, our hope is in our students and our education and how we educate the coming physicians of the future on these issues. That's why I want this podcast also to reach out and be for students who are thinking about how is healthcare or could healthcare look. And you're telling them that you want that kind of profession for them as well, where they can access these things, but it begins with how they're trained.
Yeah.
So without the students trained to think that way about access and quality, if that's not coming up in their education, they're going to be blind to this as a necessary thing, because access requires, well, let's be honest, you have to be thinking about it. If it's not on your list of things to think about, which I don't think it was when we were training, then we're not going to get there. But if you're already putting that little bug in the student's mind, our patient's mind, our policymaker's mind, then access becomes something that's crucial to getting good quality in the end and doing as well as we can for definitely the resources economically we have, but putting them into a better use and function. Right. If anybody's listening, yes, we have these conversations in our neighborhood, and they turned into this discussion. And it's not all we talk about, but I think it's really fortunate that we can have these discussions, because it shows that we live and breathe what we do to a degree. We share it with each other, and that doctors do talk about these things with each other, because it is something that we care about, and hopefully that means something to the listeners, that we are focusing on this. It's not something that we're ignoring, and we care, I think, deeply about it. So I thank you for the time to have this discussion, and look forward to people's feedback, and hopefully we can answer some questions if people do that in the future. So this has been, as always, a blast. The answers to your questions have been, always wonderful, and thank you very much.
You're welcome.
Thank you.
Fun time.
Yeah. Thank you.
So everyone, I hope you enjoyed our conversation with Dr. Silber and Dr. Wilken about some of the ideas behind how we spend our money in healthcare in the past, now, and looking towards the future. If you have any questions about these ideas, which basically we were all discussing from our point of view on the front lines, as we are towards the middle of our careers here with some experience behind us, we look forward to your comments, and we would like you to do so on drfethkemd.com, that's drfethkemd.com, or on Facebook, Instagram, Twitter, and now TikTok at Dr. Fethke MD as well. So I'm your host, Dr. Eric Fethke. I hope you enjoyed this conversation. We enjoyed sitting down and talking about these ideas because, as you can see, we care very much about what the future of healthcare looks like. We don't just do this for a living in the office, but we think about this outside the office as well. I hope that gives you some comfort. And until next time, we'll be talking about other topics, including implicit bias in healthcare, and we'll also be talking about what it's like to be a black physician in the United States, and we'll be sitting down with some doctors about this. And also, we'll be looking at sudden cardiac death risk and screening for children, a program that I've been working with for almost 10 years. So these and other topics I look forward to having shared with you, and our guests are very exciting to be with, and I hope that you are getting some good feedback and some good information about our healthcare system on this podcast. So until next time, I'm Dr. Fethke from the Pursuit of Health podcast, wishing you well in all your pursuits.